Disclaimer: the information provided on this podcast is for educational purposes only and does not substitute for professional medical advice. Thank you and enjoy.
Welcome to 3P's podcast. I'm Lisa.
I'm just sorry, I was trying to sort my screen out. Welcome to 3P's podcast. I'm Sonny from the UK, and our guest today is Dr. Powers.
Hi, thanks so much for having me.
Yes, thank you for being on here. It's such a deep, heavy subject that we're going to talk about today. Dr. Powers is a board certified plastic surgeon, correct?
Yep, I'm a facial plastic surgeon and board certified otolaryngology or ear, nose, throat surgery.
Excellent. And we are going to talk today about plastic surgery after domestic violence.
Mm-hmm.
So, can you tell us how you got started in this and just tell us a little bit about, I know this is like, it needs to be done and stuff like that, and just how you got involved in it.
Yeah. Originally, my background, like I was saying, is in ENT or ear, nose, throat surgery, which a lot of people think, oh, that's just, looking in ears and tonsils, and they kind of forget about a lot of the other side of things, which is actually we do a lot of facial trauma. And so I started getting interested in kind of the reconstructive side of things, both post skin cancer, but also post, obviously, violence and trauma. And so we got kind of some of that experience through ENT, through residency, and then throughout my fellowship year as well. I was at UC Irvine. I did a lot of the facial trauma there. So, and it's something that's persisted kind of throughout my career. I'm now here in Utah. But it's sadly something that we see quite often. You would think, oh, this is a rarity. Somebody's coming in for, say, they have, nasal breathing issues or something like that after domestic violence, but we see it quite often, sadly.
Yeah. I here in Utah, we have a domestic shelter. It's called the Peace House, and it's for battered women, children, and men. And I went to their annual luncheon this year, and they had a guest there that she was missing her eye because her abuser held her captive and beat her with the gun. And she ended up losing her eye. And then when I heard about what you do, I immediately thought of her because I never even thought that this was even out there, and so I just, I just couldn't believe it. And now it makes more sense, it makes sense that because you're hearing a lot more about abuse and stuff like that. So it's really, really great that you do that. And I'm sure these women, now my question is this something that they have to pay for? Like, how does that all work?
So majority of the patients that I'm seeing are female, like you're saying. And obviously the statistics on that are much higher for domestic abuse or domestic violence against women. In terms of how they kind of come in, a lot of patients will come in, they go through their insurance if they have insurance. If they don't have insurance, I definitely am able to work with them on like a financial option that would be able to be accomplished with their means. It just kind of depends, on the patient. But a lot of the time they're going through their insurance, and insurance will cover a lot of their care because it is post-trauma, whether or not it's a fracture, a facial fracture, or whether or not it's like we're talking about, somebody that can't breathe through their nose because they've had sustained a blow or something like that to the nose, where their nose has now had a deformity. So
Do you ever come into finding out how that happened or what happened resulted to their partner, so you know the whole story for every patient. So that's very deep for you to have to deal with that.
Yeah. I think it's actually really important to acknowledge that. I think maybe some providers that do a lot of trauma, we see it all the time. We see different trauma, whether or not it's a car accident or, domestic abuse. But I think that it's actually very important for me as a provider to kind of have that connection with that patient. And I like to make it a very safe space. Number one, talking to them, making sure that they feel like they're out of that situation, or at least have moved towards some sort of ability to have somebody else that's their safe person. Because I know a lot of the time people are not able to get out of those situations quickly, right? Because for fear of retaliation. So I think it's important to be able to, provide them a hotline number, provide them information for where they can find that safety. Because I think that's first and foremost is like making sure that that patient emotionally is taken care of before we think about, doing any of the other surgical options for them.
Yeah, because my next question was, when you do the X-rays and stuff, say somebody had a fracture in one cheek, and you can look on an X-ray, maybe they got beaten before, but obviously didn't ever go to the hospital. Can you see past fractures that obviously are healed? That
Yeah, I actually recently, sadly, was able to take care of a patient, and she had two prior nasal surgeries before, and then it turned out she had a lot of rib fractures. And talking with her even after the surgery, the reason I knew that is because I needed to actually harvest a piece of her rib for us to reutilize to reconstruct her nose. And in doing so, we saw her rib and said, "Oh, you have a lot of fractures here." And she, because again, of all of kind of the trauma she had been through in the past, didn't really remember that particular incident. But she's like, it obviously could have happened because I was very out of it after a lot of these incidents. So.
Yeah.
Now, before you do any of the reconstruction, are most of these patients of yours in therapy? Are they seeking help? And have they left that partner, most of them, or?
Yeah, most of the patients that I'm seeing, now I do a lot of surgery, like outpatient type of surgery. So a lot of patients are coming to me in clinic. Definitely a different landscape than when I was seeing patients immediately post-trauma in an emergency department. So in my career right now, I'm seeing a lot of patients that are kind of coming in and they've taken those steps. A lot of them are in therapy already. And talking with them, I kind of bring up, hey, by the way, I want to make sure that you're in a good state going forward for surgery because it can provoke a lot of those emotions, even with that pain kind of coming back from a surgical perspective in that particular area. It can kind of almost have like a PTSD type of, ability to kind of bring some of those emotions back up to the forefront.
Does that make you very anxious that, like, say, if somebody on the emergency comes straight in, say the abuser's done that and escaped, that maybe he's searching to find what hospital she's in and obviously could turn up at any time? Do you have security procedures for things like that?
Yeah. So if they come into the emergency department, and again, there's a known reason, there's kind of something that's been shared that we kind of know about. The front office of the emergency department is alerted, number one, to not let any person come back that's not on like their safe list of people that they would allow to come and see them. And then number two, oftentimes police have gotten involved as well. And there's an incident report that can be written up. The police can have that person flagged. So there's all sorts of other safeguards that can go into making sure that that patient is really safe once they're in the emergency department. I know a lot of the time for a lot of these patients and a lot of these women that are going through this, it's hard to even get themselves there. They're kind of dealing with that emotional turmoil of like, okay, how can I safely leave the house without him knowing? Or how can I safely seek help without him knowing? Like they may be so controlling or in a situation such that they won't even let them, contact a friend or something like that.
Now, do you find has just asking this. Have you had any patients that have come to you and said, look, I'm from an abused relationship and like my looks so he can't find me or anything like that?
Mm, that's an interesting question. Like in terms of what can we do surgically
Yeah.
to, you always hear about that. And people always think about that. I don't know if that comes from the media or something where they're like, oh my gosh, CIA agent has to change their whole face.
Yeah, yeah.
And in reality, most patients, I've never actually had anybody request for me to change their entire
Well, the
face.
reason I ask is because we've had women on our show that have been, abused, and the stuff they go through. I mean, I wouldn't want him ever to find me if I left,
Yeah. Mhm.
to me, it's real. I would be always looking over my shoulder, everything. So I just was curious. I mean,
Mhm.
yeah.
I
Oh,
haven't had anybody ask me that. A lot of the time, most patients are asking me, to kind of just to
yeah.
restore either their appearance, maybe it's that they have a big cut or something, right, and a bad scar, or maybe it's that they again have some sort of bony structure issue. So it's more of a, hey, I just want to look like I used to, just
And
kind of
then
that restorative healing.
you said that the police, sometimes are involved, when these women come in and everything. Now, is there cases where you've had to go and like testify?
I
Um,
haven't.
no.
Usually it wouldn't be necessarily me that they would have come in and testify. That being said, sometimes they can call on like an expert witness or something like that. But a
Mhm.
lot of the time, if that's the case, patients are coming into the emergency department, so they have kind of more of a hospital legal team that can help support those patients if they need somebody to testify.
Mhm.
But majority of the time, it would be like getting their records and that patient releasing them to their
I
respective.
guess they take photos and for photo
Yeah.
evidence if it ever does go to trial.
It's so I received a phone call on Friday, and it was just shocked me, kind of rocked my world. One of my very, very close friends, her sister was murdered
Mhm.
by her husband.
Oh,
And I just, and I said, I never knew she was abused. And she said, he wasn't physically abusive, he was mentally abusive.
mhm,
And she said that the night that she was murdered, that she thinks she went and told him that she was leaving.
mm,
And it was that control and,
mhm,
just the mental part of it that he was like, mm-mm. And I was in shock. And I'm still in shock because I just can't believe it happened.
mhm.
Um, but because you never expect your friend when you call her to say, how are you, to say,
Yeah,
my sister's been murdered,
yeah,
and
Yeah, that's crazy.
it's like a gut punch, and it's like, how
How do you even respond to that?
I you don't, and I'm just like, what, like what happened? Tell me, and
mhm,
and then going through, the shelter here in Utah, it's amazing that we have a place like this and how much they help these people out, because it's not just for women and children, it's also for men as well. Um, and I'm so glad that we have a place like that. And they say that, like, if it's in the middle of the night and a woman is, in Wyoming and she's just escaped, they will go and get her
mhm.
and bring
Yeah.
her back and escort her back. So it's yeah, I just how do you deal with it mentally?
Yeah. I mean, I think that it's important to understand where people are coming from,
Mhm.
and to kind of really, try to get more of that kind of support system available for them. I know that, I'm not a social worker, obviously.
Yeah.
I'm not that person that necessarily can make those calls, but I definitely can ask those questions to those patients and kind of try to get it in their mind like, okay, there's other things that we can be doing besides kind of your first encounter, which may or may not be with the healthcare system, but there's, other resources out there for them, and just kind of reiterating like, hey, you did nothing wrong. This is not anything that, you should be internalizing as your fault, and just trying to reiterate to them like that they're a valued human being. I think that really, goes beyond kind of sometimes what they're thinking. But emotionally, yeah, you have to think about, as a provider, like checking in with my own emotions and saying, okay, like I got to make sure that, I'm kind of keeping that area in my mind, but not necessarily letting that emotional area take its toll on my entire career.
Has there ever been a case where you felt like you had to go speak to somebody after, like that's affected you more so, or many cases where you've had to either talk to your partner or even another doctor?
I see what you're saying. Yeah, for my own emotional health and my own, yeah, I definitely decompress often with my partner, my husband. He's kind of my rock in that way. But I think it's important also as a healthcare team to be able to talk to the other providers that are taking care of that patient. So the nurses, other physicians that might be involved, and making sure that you're checking in with them as well. But yeah, I think it's important to like bring that to, again, like knowing that that's an area that you work in, being able to kind of still support that patient, but also have an emotional disconnect in some way, right? To be able to like live your own life and not have that fully affect you.
Now, have you had patients that, you've performed reconstructive surgeries and then a year, 2 years down the road, you've seen them again?
Mm-hmm.
That's
Yeah.
a good one.
Yeah. Long-term follow-up is always hard, no matter who the patient is, but it's great when I get to see them back, or just even hear from them, say, hey, I'm doing really great. Like, thanks so much. Like, this was, really, really helpful. I actually had a patient recently who I did their nasal surgery, and again, she was like, I just didn't know. She instructs yoga, and she's like, I just didn't know like I could breathe like this again. She's like, it just made such a big impact. And she's like, and I notice it in my breath and like connecting that back to my body in my yoga. And I think that was really, a very nice thing to hear back. I'm like, okay, like that makes me feel like every single day, like she has some impact in her life.
Yeah. And then, so you haven't had like women that were abused, had like a broken nose or a busted cheek, and then you fix it, and then they've come back with a different broken cheek.
Oh, I see what you're saying.
Yeah.
Yeah, I kind of thought that was the question. Got
no,
lost,
that's okay. But they
nice
I think it's great that they stay in touch with you, because you're like, oh, because you would want to know where they all go. Yeah.
Right. I want to know like everybody's doing great.
Yeah.
I've not encountered that where it's somebody that like has had multiple traumas, and then I'm the provider that tends to be, the only sees them.
Maybe to take it to that stage with the hospital and get that help and support, that's where they finally took that step to say, I'm worth more than this.
There might be a different provider on call, or something else, but that being said, I'm sure it happens where you see somebody multiple times.
I was going to say, because if you did, that would be I suppose that'd be upsetting for them to sit back there with you to then have the same conversation again and say, well, this is what's going to happen if you go back there again. I won't see you next year.
Yeah.
Which is a bit heartbreaking. That's kind of strange, because after this conversation, you never really think of that ripple effect. You see people being abused and pictures of people being hurt, but you don't see then they have to then recover, and then the ripple effect have on the doctors and everybody who like has to try and make them feel better. It takes months and years, rather than you just see a picture of someone with a broken nose or black eye. That goes on and on and on.
Well, even too, if there's children involved too, the kids see mom or dad being abused, and then maybe they get in a bad situation too, because that's what they were raised with, and that's all they know. So it's just, I just think it's so, like, I've never spoken to somebody that suffered direct abuse until we had a guest on here. And when she said, like, he almost killed me several times, and then hearing about how like most abusers hold their, you know, person captive, or they kidnap them, like, and beat them and do all this stuff. And I cannot, oh,
Yeah.
I can't fathom it, you know. And I never even thought about women going and having reconstructive surgery, or men having reconstructive surgery after.
Yeah, and then having to, that's basically like trying to relive it while you're being repaired, because you've got to open up and tell everybody exactly what's going on. I suppose after holding that in for so long and trying to avoid the hospital, I've got to that point where I've got so bad that you actually have to, you know, you have to live with the truth and open up to recover. Like you say, if they got broken ribs from years ago because they never went to the hospital, or fractured cheekbones because they just sat at home, or probably, like you say, weren't allowed out of the house.
Well, and she said she didn't remember.
Yeah.
Because, you know, it could have been at any given time, you know, that she was abused. And it's like, oh my gosh, she didn't even know ribs were broken, you know.
How many times you've been hit in the ribs that she don't even know when it actually happened.
I think what's so hard too is like we see a lot of the physical abuse, but then there's so much other mental and emotional and financial abuse that is happening at the same time, you know, with financial restrictions as to who they're allowed to.
Yeah, well, I've got friends that have dated women, and they're not bad looking women. Obviously, they're attracted to what they do, and if they're models, and then after 2 or 3 months, like you never see them modeling no more because they're like mentally abused and saying, why you keep putting yourself out there, and you change that person. I think if that's what attracted you to them, that's what you like about them, why would you change that? Because that ain't going to be the person you want to be with. They ain't going to be happy because they can't do the things they like to do, and then they feel like they just want to keep you happy. So once they listen once, the bloke will never stop, or man or woman. You know, it can go either way.
They've isolated them, like you said, financially, that, you know, like Zara that was on here, like she said she had absolutely no friends. She had no family to turn to. And she said she just ran.
Yeah.
And what ended up happening with her was she didn't have friends. So she met these people that weren't friends, and she got into a whole nother like addiction. And that to me is what would be hard, because it's like you have nobody. Where is your support group? Because they've isolated you so much. And then you have all this reconstruction done, and you're like, okay, I'm ready to get my life back, but who do I turn to?
Like, who do you even have that's going to be able to pick you up from your surgery, or kind of helping you with recovery?
Yeah, but that's what draws.
I think that it makes a lot of sense. Like if it's an acute, you know, surgery that needs to happen, it's one thing. But if it's something that can be planned out a little bit more, really that conversation, I always think that needs to happen with the provider and the patient, and saying, hey, like, who do you have afterward? And making
set them up, maybe set them up in like a group, to say like every Wednesday there's a group, so don't go be on your own, go speak to other people, come find more friends, because I suppose that's what draws people back, because the mentality and like the manipulation, they feel so worthless and without anybody, that they're the only all that person has to do is then start being nice to them, mess with their head, and get them back to exactly where they want. Because again, there's no support once they're out of that hospital, like you say. If they've been taught that they've got no one, they're going to have no one.
Do you see like the age dynamic? Is it like within a certain age group you see more of, or a different, it's just varies?
Yeah, it varies. There's not one age demographic you can kind of put patients in that have kind of gone through this. I feel like, you know, we usually think, oh, maybe it's somebody younger, and then you think somebody would be getting out, but there's some people that have been in this for years, and, you know, you're maybe just finally seeing them.
When you say us more, the percentage towards obviously women being in rather than men, what would you say that percentage was?
Oh, gosh.
Men to women?
I've personally not taken care of any male patient that has been subjected to domestic violence. That being said, I know that that's obviously not, it's not 100% women, but it is definitely heavier on the female
Yeah,
side. I couldn't put a percentage on it though in terms of.
yeah. I think that's more the case that most men wouldn't arrive at at the hospital because of maybe pride or ego, being a
Yeah, I
man.
don't know. Yeah, I'm not sure. Versus more
Yeah,
the mechanism of abuse, may be such that it's not necessarily so
that
violent.
more physical. Yeah,
Yeah, but that being said, there's obviously exceptions to that being the major trend.
yeah,
Well, and like there's a couple in Hollywood right now that's on the news that he was abused and he had a black eye. He's got like big bite marks on his arm and stuff. And it's like, and he said, please don't video me right now, And it's like, my gosh, and they were like, yeah, he never like responds to it. But yeah, I mean, being a guy, I'm sure it's a huge ego thing and, but you would never ever want to retaliate because then you're going to get in trouble.
yeah,
Oh,
Yeah.
yeah.
And I think it's interesting too. I've heard that men that go through abuse are less likely to be believed, or that they're
Oh,
when they do come forward, maybe that's not necessarily as believable of a story, and so that can also be at that as well. That they're saying, "Well, I'm not going to be taken seriously. Maybe I don't even go."
yeah.
yeah.
Well, it's interesting because my friend, that sister was killed by her husband. He shot and killed her and left her.
Mm.
Went back, slept, went to lunch with a friend the next day,
My gosh.
and told his friend. His friend then drove him to the police department and he's claiming self-defense.
Hmm.
I'm like, well, would you have gone to lunch? Would you have, you would have
Yeah,
called 911, like my wife is attacking me or something like that.
yeah.
And
I've
I'm
spun
like,
round and this has happened. Yeah, you've actually gone out for the day, then gone for lunch. That's a bit.
yeah, and
Mhm.
you left her,
Mhm.
and that just, yeah, it's heartbreaking. I can't even fathom, but like here in Utah, we have this high profile case that's happening where the wife poisoned her husband,
Mhm.
you know? So it does happen. I mean, she didn't beat him, but she definitely killed him.
Mhm.
So
Mhm.
yeah. But I think it's such a mental thing too, is when, to me, it would be like, I've got to heal my mind first. Then
Mhm.
do you find they heal their mind first and then physically heal themselves, or vice versa?
Mhm.
I, I don't know how, I mean, I don't know as a woman what would be easier to do first. I mean, they're both probably difficult, but
Mhm.
I think the physical aspect would probably be the easiest. And then, because you're probably mentally going through this the rest of your life, like you said, PTSD.
Yeah. I've seen the dichotomy on that. Um, and I think again it kind of comes when what era of their life are you meeting a patient? Um,
Mm-hmm.
some patients that I'm seeing now, they have had abuse years ago, and it's not an acute injury that they're coming in for,
Okay.
but it's definitely still in the forefront of why they're not, either breathing, or maybe it's that they have, some sort of other functional issue or impairment after that abuse. And
Mhm.
then the other dichotomy is when you're in the emergency department, when you're working and taking trauma call, and you're seeing somebody in the immediate setting right after this has happened within the first couple days, it's a different kind of conversation almost. Um, Somebody that I think that has had that abuse years ago that's now coming in has probably started to process some of that mentally. And a lot of those patients that I'm seeing are saying, well, I've already seen my therapist, like I'm talking with my mental health provider. I know this is going to be an emotional situation going into a surgical repair of this area, they kind of know it might provoke PTSD. When I bring that up to them, it doesn't seem like a new concept, in other words. So I think that they've done a really nice job of trying to do that emotional healing before they're thinking about the physical healing. And I think that ultimately leads to a very successful surgery, because then they kind of are prepared. I think on the other side, when you're seeing somebody again in the trauma unit or in the trauma bay, and you're thinking, okay, this needs to be done in a timely manner. It's before the fractures have set and before everything has started to weld together in a way that's not, will be the correct way. That's a different conversation. And sometimes those patients actually are almost, cryptic in their way of the mechanism of how they got the injury.
Because it just happened. Yeah.
It's happened. And maybe they're not ready emotionally to face that conversation yet. Or thinking that they're going to have a retaliation again from that person that caused their physical abuse. So there's a different kind of life time point that you're meeting them at, comparative to somebody
obviously that feeling in the room must be like a lot of pressure to obviously taking steps to get to the next step, which is obviously if they settle their mind through it and then they book the surgery, that's it's a bit more calm compared to being in there and not wanting to talk and not wanting to admit what's going on. It's a lot of stress. In England a few years ago, there was a lot of acid attacks. Have you seen many acid attacks or repaired any?
That is so interesting. I haven't. That being said, a lot of the time patients may not necessarily see me right at first, because they're coming into the emergency department. Everybody kind of gets triaged. I do a lot of like bony facial trauma, and if it's going to affect like a nerve or some sort of duct that makes saliva or something like that. But if it tends to be on the skin, like an acid burn, they might actually see like the burn unit type of physician.
Okay.
But that being said,
I remember those. Yeah.
That just randomly started coming out of nowhere for a couple of years. That was just in the paper, and there was lots of people going to prison for it. And I guess that's jealous boyfriends and girls getting away from them, and they're trying to. I think one of the women become really famous. She's actually a model on some. I think maybe L'Oreal.
Yeah, I do remember. Yeah.
And I just like he tried to make her, obviously, because she was a beautiful girl. Obviously, still a beautiful girl now, but he tried to degrade her to a point where she felt worthless, and obviously he made her famous. So again, he's went to jail, and his actions went the wrong way.
Yeah. I feel like even though we all know that like emotional health and emotional beauty and mental health is what makes a person, I ultimately am like, okay, well, now that person has to live with presenting themselves in a way that's not congruent with like how they feel emotionally the rest of their life. They have then this kind of like mark on them that then you have to explain it, and it's just absolutely horrendous. I mean, that would be horrible.
Well, and society is just cruel. And I just, and I can say that because you've met my husband, who is different. And so, and that's the thing. It's just people, and I've lost friendships over people telling me, you can't marry him. Why? What's society going to think of you? And it's like, you don't love what's on the outside, you love what's in the inside. And like that model, like he tried, to burn her because she was beautiful, but she's still the same person on the inside. And he didn't achieve anything, and he's in his prison.
I guess it's as long as she can feel beautiful in herself from what he's left her in. Like, obviously, like you say, so they can do as much as they can, but if in her heart she doesn't feel beautiful, but she's obviously doing well. So without all that boost and all that support and becoming famous, she must start truly believing that she's still a beautiful person. Yeah.
So if anybody suffers from domestic violence, we will provide some numbers for you. And please get help. And Dr. Powers also does another reconstructive surgery that is becoming quite a topic in the news lately. And I know I have a lot of questions, and it is gender reconstructive surgery.
We call it gender affirmation surgery.
Gender affirmation. Okay. Um, and my first question is, do they, when somebody comes to you and says, I want to have this surgery, do they have to have any certain amount of therapy, counseling, anything? Because to me, when I think about it, I think, well, this isn't just a tattoo you're going to put on, and then maybe in 10 years, you're not going to want it anymore. So what kind of therapy or stuff do anybody have to do to have this done?
Yeah. So when I see patients that are in the transgender community, again, I do facial plastic surgery, so I only do face from here up.
Oh, okay. Okay.
There's differences in the amount of psychiatry or psychology support letters that are needed for transgender healthcare gender affirmation surgery, depending on the location of the surgery on the body. Interesting.
Oh, okay.
So if you look at kind of the guidelines, it's through this organization called WPATH. The WPATH is a World Health Organization that specifically gives guidelines to providers about transgender healthcare. And so it's different if a patient is going through top surgery. So if they are female transitioning to male and are going to have breast tissue removed, that would be considered like top surgery, or vice versa. So male sex born at birth, transitioning to female and having implants put in, that's different, right? That's top surgery. Bottom surgery, which we consider to be like penile or vaginal construction, is different as well, and that's done by plastic surgery. And then I do specifically kind of what I can talk on is facial surgery. So I can do facial feminization or facial masculinization. And when people come in, kind of back to your question, like how much support do they need in terms of their mental health and kind of making those decisions and making sure that this is the right time for them to be going through a surgical option. I talk to them about this. Technically, the guideline for facial surgery is you do not have to legally have a letter of support from your psychiatrist or your psychologist. That being said, I think that even if you think about patients that are cisgender, right, that identify, born male, identify male, born female, identify female, even if you think about patients that are cisgendered, you really do think about this is a huge still transformation depending on what they're doing and what they're changing on their face. And I think it's the exact same for the transgender community in terms of that being a big emotional change that has to happen in addition to a physical change. So I do encourage my patients to get those letters, to have a psychiatrist or a psychologist that's going to be in that support system that they've been seeing. And I do like to have those letters before we go through a surgery.
And have you ever turned a patient down because you don't feel they're in the right mental capacity for it, or?
No, but that being said, a lot of patients that are coming in, some people, it's just a conversation that we're having to begin with. And that information that they gather in our consultation appointment can then be taken back to their mental health provider and they can have that discussion. So it's not necessarily like a dichotomy of like yes, no. It's more like, hey, it has to be congruent kind of with what they're looking for, and also having kind of expectations that are pretty reasonable as well. So when we talk about like facial feminization, we talk about, if you think about the area that makes the face look the most masculine or feminine, we would divide the face up into the upper third, the middle third, and the lower third. And interestingly, it's the upper third that we really do think, okay, if you looked at somebody just from that area up, that you could say, okay, they have more feminine features or more masculine features, depending on how heavy their brow bone is and how much they have frontal bossing on
I
there.
keep looking at Sonny.
Yeah.
I was thinking, can you sort this big baggy jaw out?
So it depends on the patient, and it depends
Mhm.
on if surgery is in their discussion in terms of their transition. But if that's the case, again, I always tell patients like surgery is not necessarily, it doesn't have to be for everybody.
Mhm.
But if it's part of their transition and part of what they are kind of going through with their plan, then that's what we're here for.
They do
So
like skin shaving and stuff where they, like you say, if they want to thin their jaw out and stuff like that.
yeah, so in terms of like the bony structure, there's a certain amount of bone that we're born with, right, that you have to have for a functional mandible, for a functional jaw to be able to use that. So there's certainly limitations that we can do, but we do have patients that come in and they say, hey, can I have the angles of the mandible sculpted down, or can I have the chin sculpted down? But if you think about some of the more feminine features, like some of the more prominent people out there that have pretty prominent mandibles, or those angles that are pretty, that are pretty drastic, or like Angelina Jolie,
Oh,
like,
yeah.
very feminine, we would think, oh, absolutely gorgeous human being, but really does have quite a chiseled jawline. So
Yeah.
it just depends on kind of the patient.
Hmm.
Yeah.
Now, do you see like an uptick, like it's more people are considering this now than versus 5 years ago? Because it seems to be more accepting now. People are talking about it more. Do you find that it's becoming, more of a surgery that you're doing?
I think that's hard for me to answer because I'm new to Utah.
Oh, okay.
New to practicing here in Utah. Majority of the transgender healthcare I was doing was in training with his name's Dr. Scott Chiat out in Wisconsin.
Oh, okay.
And it just depends. I think part of it is if you are new to an area, kind of making yourself known as, hey, I am a provider that offers these services. So I'm trying to kind of grow that just a little bit more, but it's hard for me to get a pulse on that just because I've moved different regions and I don't know if it's regional.
Well, that's what I was going to ask you. How is it going in Utah? Because but I mean, yeah, I just am wondering because,
Yeah.
this we live in.
Lisa will be with you next week.
She gets it. She gets where I'm trying to go with this.
Yeah.
I don't want to say it without saying
this?
it.
Yeah. Yes. Utah traditionally is a very conservative state. And I think that interestingly, Salt Lake City is more progressive than I expected coming here.
It is. Yeah, it
Yeah.
is.
Lisa's like, are you busy? How busy are you?
Yeah.
And so down last weekend down in Provo, there was one of the 1 in 3 in the nation transgender pride festival. It's put on by this place called Gender Bands, which is in Utah. And I was really surprised at how many people I had come by. We had a little booth there, kind of letting people know, hey, we're here. And there was 400 volunteers. There were over 200 people that stopped by our booth. I
Wow.
feel like there's a lot of patients, not necessarily patients that are new, right? These are all people that have existed for years and years, but there's more visibility, like you were saying, there's more acceptance, I think. And I think a lot of patients or a lot of people, that are transgender are kind of more open to, to kind of being more visible out in public as well.
Yeah.
Yeah.
It kind of seemed to be like the next phase, because that was like 15 years ago, that was tattoos, and now it's a bit more acceptable. And now this is the next phase, surgery, where people are a bit more, let's just do it. Everybody's doing it. If you feel insecure about that one thing, just get it done. Which again, shouldn't really be an issue if you're just trying to make yourself feel better. So it shouldn't be anyone else's opinion on what happens, as long as you feel better.
Pretty consistent with cisgender or transgender patients, like anybody really, if it's something that has bothered you for years, whatever it might be, as long as you have realistic expectations, I think that that's fine. I think that the patients that come in that are doing things, say they have somebody that said, oh yeah, you should really get this done. I mean, that's really the reason not to have surgery, right?
Yeah.
Surgery should be done for functional reasons or for an aesthetic reason, but it should be for something that they want. Yeah.
Well, because I mean, I'm gonna tell you the truth. I watch Botched.
Yeah.
And some of these, and I'm really, really curious as a plastic surgeon, if like I see some of the men come in that want to look like Barbie, or the girls that want to, have like all these surgeries. I mean, obviously there are some doctors out there that will keep performing and performing all these surgeries. Do you find like how do you feel when you like have like a guy that comes in and he's had all this surgery done to look like a female, and they look like a female and they're beautiful, but it's never enough? Like, how do you okay, I'm drawing the line here,
I think that not necessarily even male to female, but just even
or
somebody,
hey,
I really want this, this, and this. And then, if you're talking to them as a provider and things like there's a sense, there's like a spidey sense, I guess I would call it. I don't know how, but you read patients, and when patients are talking to you about, I always jokingly tell this to other providers. I'm like, yeah, if they're like, do you see this little thing on my nose that's present on the first Tuesday when there's a full moon and this light? And it's like, if you can't see it, if it's not reasonable, then don't go after it. Like, what's your end point, right? And I think it makes a lot of sense in anybody to kind of have that conversation. And sometimes it's like, hey, I just can't see what you're looking at. Like, can you show me a little bit differently? And most of that time, that sparks that conversation of like, am I going to actually be able to meet your needs with surgery? Probably not. And so, I'm pretty conservative in terms of the like what I offer versus what I'm asking to be able to achieve. And I've always been told, like, if the goal line is here and you're right here, it's probably going to be worse with surgery. Like, you might actually not get to that goal line, but if your goal line is here and you're over here, and really the improvement you can make surgically is pretty reasonable, and that patient has that understanding, then that's a great surgical candidate. But again, that really does come back down to reading what that patient is asking you to do, being realistic with them, setting goals with them, because if their goal is something over here and you think you're talking about this goal, you might achieve the goal you're thinking of as a surgeon, but they might be really mad at you later and say, hey, we didn't even address whatever it might be. So it really just is that first conversation. And then secondarily, if you do see somebody where, I actually did have a patient the other day that came in, they had a ton of filler other places, different other surgeons around the area, had gone and flown for different reasons to different surgeons elsewhere outside of Utah, and had a bunch of injections, came in really looking overinflated, like huge cheeks, huge lips, huge everything, and wanted me to go in and like do a really specific area, like another little bit of filler, like right here compared to here. And I just, it's that conversation again. Hey, I'm so sorry. Like, I just don't think that I'm going to be able to be that provider for you.
I think maybe you need to go see a psychiatrist, a psychologist or something. Yeah, because, and that's a thing too. I think before like transgender and all this was, commonly accepted and everything, I think so many of them may have gone to different countries and have it done. And, you've seen some of the results of that.
Right. And also you think about the worry of if there's complications down the line, not having your surgical team readily available to be able to help you, because you can't fly back to whatever country you may have gone out of country
And I
for.
guess that's like finding the correct professional. Like you say, you'll turn somebody down if you don't think you can meet to their standards. But you got other doctors in different countries who just want that money and will do whatever they ask of them. And if they're not happy with it at the end, then they'll have to pay again to reconstruct that. And again, you're happy to turn that money away, because that's actually your profession, is just to try and make the best for somebody, which is good.
Now, I don't want to throw you under the bus, Sonny, but I know I know somebody that went to a different country for some surgery.
We looked in London, but then we looked in this place in Turkey that had 65,000 5-star reviews on Trustpilot, and I thought, I went through so many, that one just kept coming up, and I just said, I thought I've just got to go, and we went to Turkey, and she had the best job. I couldn't fault her. And again, like you're saying, that was scary to say when we come back, the surgeons and that on our doorstep. But they did say if there was ever a problem, they messaged us like every day for like 6 weeks to check and take pictures and send. And the doctor would always have a look to see how that was healing. And if they did say if anything ever looked out of place, they would pay for our flights to go back and have another look at it, like if the stitches weren't right or something. But that's, touch wood, they're beautiful.
And there are great surgeons in every country. That's the thing. There are. Every country has amazing surgeons. It just depends if you're going to that person, right? It's hard to know.
How do you know? Just because
like in America, we have bad surgeons here, right? There's some people that probably shouldn't be practicing, and there's some people that shouldn't be practicing in other countries too. And so it's so difficult to be like, okay, are you shopping on price? Are you shopping on, and it's hard, right? Because obviously price is a factor, quality of work is a factor, and accessibility for care is a factor. So it definitely depends on what you're kind of willing to compromise on. And it happens everywhere.
The price was a lot cheaper, I have to say. Well, I think that was in the centre of London with a surgeon, that was 7,000. We spoke to a surgeon, and on the dates we wanted or we could get away with sitters for our child, that he wasn't available. And then we checked all these places, and then they kept on this, I can't remember what it's called. I like to big them up now, but I can't remember what they were called. There were so many 5-star reviews on this one surgeon, and then there were so many photos before and after that I just kept showing my partner, and she said they'd done such a good job. And I said, well, if we request him, we can have him. So that's what we had, and he done a really good job.
Well, that's good. Yeah, that's really good. Because it's so funny because, as I've hit that magical age, and a lot of my friends have, things start to go south, and
gravity wins. Gravity wins.
Yes. Yeah. And some of my friends have had things lifted to the north. And it's funny because I have said, oh, would you refer your doctor? And they have said no. And I said, well, why do you say that? And it's so funny because when I look at them, I'm looking at like, I think they look beautiful, and they're like, well, this side is coming down quicker than this side. And I'm like, I don't even notice that, And so it's like, well, how then do you find? Because I know these women, they've researched, they went to Chicago to have it done. They went to California to have it done. And how do you even know? I mean, he could be the best surgeon, but your body just reacts differently.
Yeah. I mean, surgery in general, it's not a perfect science, in that, it depends on how you heal. It depends on how long your swelling stays around. We usually tell patients a timeline of like, okay, well, when are you going to be fully healed? Interestingly, like for a rhinoplasty, if somebody comes in for their nose, it's a whole year to a year and a half, depending on how thick their skin is. And so, having that, again, that conversation up front, I think when you go in to try to select a surgeon, if you're like, how should I make sure that I'm finding somebody that's going to be able to be doing the surgery that I need, and that also is going to kind of make sure that they're with me that whole way, is asking those questions like, okay, how often is it that complications happen? when they happen, like what type of care is given, understanding like how long it's going to take you to heal, understanding like what's normal and what's not normal. And those are things, again, your surgeon should be telling you before you even think about having a surgery booked with them. It's just that informed consent conversation that should happen right up front.
So see, I've had a lot of skin cancer, mostly on my nose. And I've had a lot of well, they've done reconstructive surgery, but I haven't gone to like a plastic surgeon to get, and my nose bugs me to death. But I'm so afraid of if I got it done and I didn't like it, then what? It's like, so I'm like, well, I live with this like deformed side of my nose, and so that's my biggest fear because, and then also the pain. So I don't want the pain.
Like, oh, if I make this change, I'm not going to be able to go back, right?
Yeah.
And it really just depends. It depends on what you're trying to change. And I always tell patients, like, unless it's cancer, right? Unless we physically have cancer and it needs to come off, majority of what we're doing is purely elective surgery. And that might be elective to make your breathing better. Maybe you don't breathe out of one side of your nose after you had, right, a cancer or something taken off and it was reconstructed. Or maybe it's purely for the way that it looks, right? But either way, that conversation really, again, that patient needs to have that conversation with their surgeon, and that patient needs to be the one to make the decision, yes or no, for surgery. It shouldn't go to anybody else. That's their
I think you're having that conversation now.
Exactly.
You're funny.
You're booked next week, babe.
Hey, I'll tell you when we're done.
Like, does it bother you enough?
Yes, it does.
Yeah, that's usually what I tell people, and everybody.
You know what it is? I think there's so much scar tissue that's like, I've had like holes put in it to get oxygen to the scar tissue. Like, I've tried a lot of things. And but it does affect my breathing and stuff like that. But back to let's get off me.
I love it.
When you do like the jawline, so you can make like the jaw pretty dominant and everything. Then do they then go on like hormones and stuff to grow facial hair and stuff like that? And then is that like somebody else? Like then they have to go to somebody else to get that done. So there's like different stages of doctor during the the surgeries and stuff.
Right. So if somebody is, so we talk about like, okay, what was your sex assigned at birth, right? Female versus male. We say that's technically, but then we have the scale of gender, which is fluid, right? Which can be non-binary, all the way male, female, and then anywhere kind of in between. So if somebody's coming in and they want to have a more masculine appearing jawline, interestingly, this is what's kind of interesting. So I oftentimes will meet patients after they've been on hormone therapy. They see a completely different provider. So there's a different provider that does that. It's either like an endocrinologist. Sometimes it's somebody like a family medicine doctor or an internal medicine doctor that starts them on hormone therapy or maybe puberty blockers, depending on what age that they're being started on. And patients that come in that are on supplemental testosterone is such a powerful medication in that you will see changes like facial hair growth very, very shortly thereafter.
I just had testosterone pellets inserted. And I said, am I expect anything? She goes, no, we're starting very, very low. I was like,
depending on your dose.
Huh?
I thought I could see a mustache.
Oh, no. So testosterone's interesting compared to estrogen. If you put somebody that is an XY chromosome, right? So born male sex at birth on estrogen, you will get some fat redistribution in the face. Like you will see some improvement in terms of like the amount of fat that's in the cheek area, but it's not super drastic. And usually you'll see that at about like 2 years where it's going to be settled out.
Wow. Okay.
Whereas somebody that's on testosterone, you might see facial hair growth. You might actually hear pitch change in their voice, and changes that happen a little bit more drastic with testosterone than you would with estrogen.
Gotcha.
So
Okay.
a lot of times the patients that I'm seeing, a lot of them are actually coming in to see me for facial feminization because testosterone is such a stronger, ability again to like create facial hair, to have some of those more masculine features. But yes, you're right in that there's a different provider that does their hormone therapy, that does all of their labs and kind of monitors that, both pre-surgery and post-surgery.
So when you say feminization, are you talking like cheekbone, like you add cheekbones and
Depends
like
on what the
soften
patient's
features?
Yeah, it depends on what the patient is interested in. And so, again, when you look at somebody's face compared to somebody else's face, not everybody has the same type of features. And so sometimes it's that brow bone, like we talked about, or like the heaviness of an eyebrow, or maybe the eye is not as open. And we think about like a more feminine eyes having like a more open feminine eye.
Yeah.
Maybe that is cheek implants. Sometimes people's cheekbones are much higher than others. It just depends. And sometimes we think about that also involving like nose, right? So if you look at a nose and you say, okay, is that a masculine looking nose or a feminine looking nose? Feminine looking nose tends to have more of an upturn and more of a rotation of the tip, and tends to have less of like a hump or less width in the bone area. Whereas like a masculine nose, again, couldn't be plus or minus a hump. And then the tip is actually coming out more like at,
Turn to the side, Sonny.
Pardon?
I said, turn to the side, Sonny.
I hate my nose from the side. I hate it.
And I think everybody, because like my background, I'm Italian, so I feel like all the Italians have that hump, and I'm like, oh, that's a little masculine.
It is neither necessarily, but yeah.
But I will watch a nose job on television, and when they bring out that hammer, I'm like, oh, I can't wait.
Just that tap, I go, oh.
When the chisel comes out, you turn the sound down.
Oh,
I just push that in.
and that's
just
what I'm so afraid of.
Yeah.
Yeah, but you'll be asleep.
A lot of surgeons back in the 80s were still doing quite a few rhinoplasties under just like a little bit of sedation and local anesthesia. So patients were awake to hear those. And I guarantee you a lot of my patients would never elect for that. They'd say, absolutely not, put me to sleep. But
so one of my skin surgeries, we were living overseas, and I was awake through the whole thing and smelling my flesh burning. I was like so sick to my stomach, and my head was, and I'm like, time out, like, and then when it's on your nose, like you can look down and see what they're doing.
You'll be holding a mirror saying, no, a little to the left.
Knock me out, please.
You didn't like the smell of human barbecue.
Oh my God.
It was 5 hours.
Yeah.
And I was like so nauseous. And then at one point,
it's made me sweat.
Oh, the one point the Novocaine or whatever started wearing off. And it's like, okay, I'm starting to feel some things, but it was the Mohs surgery. So it's like, they can't put you under because then they got to test everything. You got to go out and wait,
Right. It's a much longer process depending on how many passes they have to do.
Oh my God. He did a lot from here all the way up to my eye. And I was like, oh, please. I'm like, iodine and baby oil was okay when I was about 10, but now I'm paying the price for it. So
yes, I totally hear. You know, what's interesting too, is in Utah, we have the highest rates of melanoma in the country.
Really? Because everybody's outdoors?
I think it's a combination of we're at such a high elevation. So if you're at a higher elevation, then you're going to get more UV sun exposure. And then we do have quite a few Caucasian people that live in Utah.
White,
And
white.
very white here.
Yeah.
And then, yeah, everybody is very active, biking, skiing, everything that people are doing year round. A lot of places are like, oh, in the winter, we don't do anything. Well, in the winter here, everybody's still very active. And then you get that reflection.
I was going to say, people are fried. Yeah. You don't realize when you snow ski how fried you get.
Yes. So you're doing it from here. And
and then
snow.
Well, you can yell at Sonny because I'm sure you were at the beach all day today, Sonny. Did you?
I know my face is so red. I keep seeing. I think.
Oh no!
I'm trying to face the light because I've had the sun on me all day.
You need mineral-based sunscreen.
Yes.
Mineral-based sunscreen, so you block UVA and UVB.
It's been so windy, so I thought, oh, I'm fine. And as soon as I got in the car, I thought if I put the aircon on. As soon as I'm out at home, it's like I've got no breeze and I'm so hot. Yeah. I've got this big fan beside me blowing.
Yeah. Well, and I grew up in Arizona, where we would wait for the news during the day to see how long it took to fry an egg. So we would know, okay, we only have to be outside for 20 minutes and we're going to get a nice crisp tan. And then we moved to Australia and where, it's like, okay, so double whammy. And of course, now I'm like paying the price. So, but yeah. And
I get your skin checked regularly.
Oh, I do.
Main thing. Yep.
Yeah. And so how many would you say, well, I don't know if it's hard for you to determine, but how many like transgender facial reconstructive surgeries do you say you do like a month or so?
Oh, I see what you're saying. It just depends on the month. We have some, so for instance, like some patients will come in and we have like stages. So it depends again on what we're talking about, what features we're addressing. But for instance, if somebody's coming for facial feminization, we might do the cranioplasty that month with maybe also a chondrolaryngoplasty, which is where you do that Adam's apple shave off. But you can't do everything all at once because purely on kind of time frame in terms of how long it takes. So it really just depends, on the patient. Strangely, it's not super painful. It's a little bit tender in that if you move your neck around, you'll say, oh, it kind of feels like you have a bad bruise.
Yeah.
There, and it's a little bit tight for a couple weeks afterward, about 4 to 6 weeks. There's kind of just this general tightness there, but it's not super painful.
I guess if you try to do everything at once, you got that recovery. And again, if just your neck hurt for a little while, you can deal with that. But if your cheeks hurt and your nose hurt and you're suffering.
Yeah. Do you also move up and down the hairline and stuff like that? Wow.
Depending on the patient. So if you think about a more masculine hairline, the masculine hairline has recession along the temples because of testosterone in the body. And if you are trying to address the hairline, we make a cut actually at the hairline. We advance the hair-bearing scalp down so you can shorten the forehead. You can actually advance this part in so that you're trying to address that temple. And then the kind of the cherry on top of all of that is after the surgery, after things kind of settle out, you can actually go in and do a hair transplant where we take hair from the back of the head and we transplant that individually into.
And you do that too?
That is what I need. I've got CVG, so if you actually
your hair is so thick.
Beautiful hair.
Oh, that's thick, but the hairline is gone. Look
quit pulling it back.
Yeah, but if it bothers you, if there's a little spot, you could just do a little bit. You can take some. So we take some individually, take the graft, pull that graft out, and the hair is grown like 1s, 2s, 3s, or 4s, depending on your density. And we, at the frontal hairline, we feather in like the 1s and 2s, so it looks really natural, but they're individually placed in. Completely different than back in the 80s and 90s when people were doing hair plugs. If you've ever seen that.
Yeah.
So unnatural. That's like a 70, like a punch graft of like 50 to 70 hairs plugged in, and then there's like a gap in between, and it looks like a baby doll's head. The advancements have also improved over the years.
Have you ever done a surgery? Because obviously my head is like a Shar-Pei dog. I think I googled it. It's like, I think it's called CVG. And honestly, I saw one picture of a surgery where they literally basically sculpt, and I don't even know. I thought I'd love to get mine done, but I saw that one picture of some surgery where they literally cut the whole skin off. You could see his skull, and I was like, no, I'm not. Is there any other
What
way?
do they do?
Because you know, like a Shar-Pei dog is all
Yeah.
scrunchy. That's what my head is like that. But it's only like
so they make it tighter.
I think they obviously cut a section of the skin out and must have tightened it. But the picture I saw, I was like, cool, I'd love to have it done, but I could not have that done.
I have not. I've never actually seen that surgery performed, and I've never had to do that surgery.
If you Google that and see that picture, you'll think, I don't want to do that.
But then the problem is, like, once you do that, then you have scars everywhere.
Yeah, I would rather have one big scar up the middle. That looked like somebody's dragged a rake down my head. There's about 9.
Yeah.
So that's interesting. So you do that hair surgery too, then?
Yeah, most of the patients that are coming in are males. Most of our patients, and a lot of them are like, okay, I don't like the temporal recession, or they don't like the scalp, kind of the crown, if they're thinning through that area. And again, it's because there's testosterone. There's certain hairs on the head that are subjected to testosterone. There's certain areas on the head that are not. If you think about somebody that has really advanced male pattern baldness, they still maintain like that horseshoe of hair in the back. Even if they're shaving it, you can still see follicles. That's the part that never thins. So knowing that, you can actually take those, you're kind of taking from the backyard and putting them in the front yard, and take them out as long as you have good density, because it's not like you're not getting new hair. You're just redistributing your hair you already have to different areas.
Yeah, you're just moving roots from one repot in the garden.
Let me ask you this. So you know how like there's all these keeps and like other pills that they say men can take. Does that work?
So depends on the medication that you're talking about. Usually that kind of brand, or there's other brands that are out there, or there's just it's prescription, it's finasteride, and that's blocking the effect of testosterone on that particular hair. It's never going to like give you new hair. So where you've already lost your hair, you're not going to restore that, you're not going to bring it back, but you're kind of stabilizing the current hair you have, in other words.
So nothing that once you're receding, that's unless you transplant it. Because it's weird because like this big Ozempic craze, Ozempic is for diabetes, and now women are using it for weight loss. Well, I know, is it Propecia that's used for overactive bladder for men, but I heard it helps thicken your hair. So I know males that are on Propecia, and I said, well, how do you get it? And he goes, I just go and tell him I urinate all night long. To me, and he's got thick hair, and I was like, what? That's crazy.
And the way that those medications are working is they're thickening the hair you currently have. Like if your hair, if the actual hair, if you looked at it under a microscope, the actual hair would get thicker. Like, you're never putting brand new hair in there.
Well, he doesn't have any receding, so he's just keeping what he's got, I think.
Yeah, he got ahead of it. He got ahead of the game.
Right.
I mean, obviously those medications aren't made for that. That's just a side effect, but is it healthy? Is it not healthy? Like,
that's what's interesting about, even like if you think about the origin of Rogaine, or minoxidil is the name of it, it was not invented for hair. Absolutely. Like that was a known side effect that happened. You can Google why it was originally invented, but it's interesting. There's a lot of different things that are like, okay, the side effects of it are actually something that they're excited about, right? And then people start using it for off-label.
Yeah, there's a craze in Norwich at the moment in the UK where there's stuff was designed for erectile dysfunction, and you have to do like an inhaler. I can't remember what it's called though. You like, you get a blocked nose, you get inhalers, they do that once every day, and they realised the people that they were giving it to were getting really brown because that changed the pigment in your skin, so that was making people tanned. So now people sell it as tannin, but it was actually designed for erectile dysfunction, and obviously that change of pigment in your skin, that tan you for like 6 months. I know this because I tried it for 2 weeks. I done it for 2 weeks, and for 6 months, my boss went, "Who is the black man on the dumper?" And I was like, I come flying past, and he said to my other boss, like, because he only comes into one day every week. He was like, have we hired someone new on the dumper? Because I'd come past him, and then I was the other side of the site waving at him, and he kept looking at my boss like, say, "Who's the geezer on the dumper?" And he seen me about 4 months prior to that, and he said, in 4 months, he said, "You just look like a completely different person." And
Seriously?
I literally, 2 weeks, and I was so brown for like I looked like I'd lived in Egypt for 6 weeks.
Oh, no.
Wow.
And I thought I'd just try it and see how good it was. I'd done it for 2 weeks. My mate said, "Yeah, do it for a month." If I had done it for a month, I would be sat here now looking like I'm from Egypt. I swear to God, I was so tanned. And I got Sabina said, "You have to stop. You have to stop."
I have a lot of other questions about that, but I'm not even going to go there.
I'll order you some. Yeah, no, the other thing's not a problem.
But back to your question, you're asking, like, okay, are these safe? And they are safe in that they're not going to cause anything like death, but at the same time, right, every medication has some sort of side effect profile.
Yeah.
So it's like, okay, well, how much, like, if you're doing that for tanning, okay, well, knowing that it was originally invented for erectile dysfunction, are you willing to tolerate the side effect of essentially non-erectile dysfunction?
That was awake all night, but that helps.
It just depends.
That's so crazy. Oh my God.
I would prefer that side effect anyway. I like that side effect.
Exactly. One of the hair stabilizing medications, finasteride, actually has the side effect of erectile dysfunction or like low libido. So a lot of patients are like, absolutely not. Like, I'm not
no deal. That's a no deal for me.
Yeah. Wow.
If my hair got any
happy or a lot of thick hair and not so happy.
Yeah, exactly. Pick your poison.
Exactly.
Yeah.
That's so funny. Well, do you want to add anything to our little podcast here about what we've covered and not covered?
I think, again, when we kind of talk about, okay, why is this relevant to your podcast, and kind of getting back to that same type of theme of, like, no matter what surgery you're going to go through with, if you are going to go through the surgery, that change has to be rooted in something you want to do. Number one, it should be for you. And number two, it should be also part of your like emotional transformative process. Like, you need to have mental health buy-in and be able to kind of have that psychological buy-in before you go through with the transformation with surgery, whatever that might be. You know what I mean? Whether it's getting your nose done after, skin cancer surgery, or it's just having that ability to kind of make sure that you have a grounded thought process, because it is kind of a freaky situation if you wake up and you're like, you know what, like, this is very different than the face I've been used to looking at for my whole life. So,
well, and I think mentally too, it's you have to, live with that change too. And then there's other people around you that, like, if you haven't seen somebody in a long time and, they've changed. And I think that to me would also be a challenge within myself as well. Like, what are you thinking?
I was thinking the same with if the transgender. Before we go through that, you have to deal with the support system and worried about what your friends are going to think, and obviously have that ability where all your friends are saying, you just gotta, we're here for you, whatever you do. Like you say, if you don't see someone for 8 months and then you turn up with a pair of boobs and long hair, and it's like, hi, and you say, I've got a friend called Henry who's been through the procedure, had a boob job, and now looks so feminine, but she's so more happier in herself. But the support system with her, and I think she's amazing for what she's done for herself. And again, you obviously never really thought about the effects that she's probably gone through before doing that. And that's, like I say, it's got to cause you a lot of stress to think maybe a lot of people let you down and just say, like, or you know, rub you off to say I've known you my whole life, but I've known you as Henry, and now.
Well,
You
so
know,
let me ask you this. Did most of her friends embrace her change?
From what I know, she's got a good support system and obviously lots of good friends, and even on Facebook, everybody's supportive. And she's like the best person to be around when you're in a room and you're having a laugh, and she's like the center of all. So she doesn't like carry away. She's like blown, like, you know, come out of herself to be who she is truly, which is nice. Obviously, down the line, there's probably people that I don't know about who have you know disintegrated and disappeared and probably lost love. But again, she don't need them people in her life if they're going to be with bad opinions and negative.
Well, and I think you made such a good point there too, because we always think about, is the patient getting the therapy that they need? But they, you know, it's like, do you have that strong support system around you as well? You know, because I think it would be extremely difficult to have a surgery like that and, you know, not having those people back you, you know, I think that would be extremely difficult.
Yeah, I think that, you know, you talk to a lot of patients that are in the transgender, or really even anybody that's in even like the LGBTQ community, right? And some people's families, when they come out or they tell them, hey, I'm transitioning, you know, this is a different response, obviously, depending on your family, depending on your societal beliefs, right? Depending on kind of all these other external factors. So a lot of patients may not have that support system from the traditional sense of somebody that was there for them when they were growing up, but now they have more like a chosen family, right? Somebody that they found.
I suppose from the newer generation, if you're a young parent and your child want to transition, that's a bit more adoptable now than having an older generation where fathers want their boy to be a boy. And again, that's sometimes maybe some people are still trapped in themselves because they can't let their father down. Again, being lost in that system from being in the older generation, and you know, if you weren't going to get that support from your father.
We even had a person on our podcast that God, there's like a mosquito. He decided to come out, but he hadn't come out to his family yet. And his family was faith-based, and he for a year pulled away from his family because he thought for sure they weren't going to accept him. And so when he sat his dad down to tell him, and the reaction he got from his dad was the complete opposite of, sat next to him, hugged him, said, "You are my son. I love you. I don't care who you love." And he said, for an entire year, that consumed me.
Oh gosh.
And because I thought my parents were going to react this way. And
he held on to that for 11 years, didn't he? He couldn't be himself for 11 years.
He couldn't be himself for 11 years.
Yeah, he went to all the sports and joined the army just to try and show people he's a man, but knowing full well he couldn't open up. So I think 11 years of his life he wasted.
Yeah. And then his parents, and he's like, you know what? I just assumed they would disown me. And, you know, and to me, that was a really, really
that was deep.
part of his story, because I was like, I can't imagine, you know, living.
I nearly brought him up earlier.
Huh?
I nearly brought him up earlier.
Oh, really?
Part of the conversation, I was just like being lost and not having the support and bringing yourself through to. But for 11 years to be like that is very difficult.
I mean, join the military.
He dated that lesbian just to show that he
just because somebody was going to come out and tell the army that he, you know, was gay. And so he met this lesbian in the army. They pretended they were dating so nobody would out them.
That was a very good, very deep podcast.
That was, and I just, you know, it's sad that, you know, you have to live in that fear or hide it, you know. So I'm so glad that, you know, they have a person to come to like you to help them, you know, be who they want to be and, live their life.
Yeah, I appreciate you guys having me on. I
Well,
know
thank you,
Yeah.
Dr. Powers. It was I usually end with a quote, but we kind of covered two different topics. And so I don't know if I have a quote. I don't know.
You can record one later after you
in post-production.
Huh?
Yeah.
You said you can put one in post-production.
Yes, exactly. I'll have Logan put it in.
Yeah, Logan will edit this.
Thank you for sharing what you do. I think it's such an important, both of the topics were very important. And like we said, if anybody is going through anything and they need help, we will have numbers for you to reach out to. We will also post Dr. Powers' contact if you want to get in contact with her. Sonny,
Yeah, not before you.
not coming to the US to do anything.
I'm going to Turkey for this in December.
Perfect. Come on over.
Yeah.
Sorry.
And
Unless
don't
I get
forget
50%.
to follow us. What?
If I get 50% discount, I'm going to
I'm sure we could work something out.
Yeah.
Don't forget to follow us on Instagram, and our links to the podcast are on there. And we will then send you the podcast and you can post it on social media if you would like. We hope you will.
Yeah.
And yeah, or like the snippets or anything like that. So I hope you enjoyed talking to us. And
I did. It was a lot of fun. It was a good discussion.
The thing is,
it's a very big eye opener as well, because there's so many little parts of that I can't get deeper and deeper. And I was like, I've never really thought of it like that. So this is good for people who are about to transition or think about surgery. Hopefully they get to view this.
Well, I never, to be honest, thinking about abuse and stuff, I never thought about the physical healing.
Yeah, exactly.
I never even thought about that. And then when Emily told me that you also do that, I was like, oh my gosh, so thank you.
Yeah. You've got the perfect name for your job, Dr. Powers.
I would say that's the only reason I got married.
Yeah.
Your husband
doesn't listen to this part.
It's a great last name.
I feel like you should have Wonder Woman cuffs on. I'm Dr. Powers.
Yeah. Is your husband called Austin?
No. He's not. But that's the perfect. Anytime I'm on the phone and they say, "Well, how do you spell your last name?" and I say, "Oh, it's like Austin Powers,"
Yeah. Have you got? If you ever have a son, you have to call him Austin.
Yeah, exactly.
They won't even know this generation.
I was talking to Alyssa the other day, and she's like, "Oh my God!" And then she's telling me all the stuff you have in your basement. She's
my gosh,
huh?
We have essentially an entire tiki bar in our basement.
That's what she said.
Pinball machines.
Like you were some renowned pinballer, right?
No. I play, but I am not that good. No.
Oh yeah, sure.
I am not that good. I will go to like tournaments. Essentially, this is like my husband's
okay.
And I was like, okay, sure. Like I'll start getting into this too. And it is a lot of fun, but I'm not good. I promise you, I'm not good.
That is so funny. Yeah, I couldn't remember what she said. It was a tiki bar. She goes, she has an entire tiki bar in her basement. I'm like, what?
Yeah.
We'll have to come over for drinks one night.
Yes, you should.
Awesome. Thank you so much.
Thank you ever so much.
What's that?
I said thank you ever so much.
Oh. It's that accent.
All at the same time.
Thank you.
Take care.
Take care.
Have a great rest of your Sunday.
You too. Bye.
Okay, bye.